Welcome to our final video in the general psychology series. Previously we looked at mental illnesses, so now let's address some of the therapies out there to try to help with the situation. We're going to focus in this video on biological therapies. And to be a biological therapy, you're saying that we believe the treatment should somehow affect the machine, the body. So we're going to be doing something either chemically, mechanically, perhaps even electrically to help alleviate symptoms or perhaps even cause or find the cause and cure the problem. We'll look first at drug therapies, which are basically used more than the other two. The other two that we'll get to, psychosurgery and ECT, are much more rare. These are psychoactive substances, so they're somehow changing the brain and the brain's chemistry. In this case, we hope to help the behavioral situation. Looking first in anxiety disorders, something that we looked at in the previous chapter, we're going to look at anti-anxiety drugs. So these medications are somehow alleviating symptoms that are linked to, and hopefully perhaps even alleviating the problem itself, to having high anxiety. Benzodiazepines are some of the most common anti-anxiety meds out there. You've probably heard of things like Xanax or Valium, and occasionally throughout these videos I will toss a few name brands to you to try to help you kind of realize what those things are that you might have seen on TV or in literature. Remember, in our previous chapter on anxiety disorders, we say the arousal state is too much, or having too much excitation of the brain in situations where you should not have it. So these medications, commonly known as tranquilizers, decrease the excitation, decrease the neurological activity. They do offer the greatest relief for anxiety. However, they do have a potential to be addictive, and that'll be a common theme throughout some of these medications. Now, benzodiazepines are those things that help reduce anxiety, but like any medication, we have to recognize that there are side effects outside of treating the specific illness or problem. Given the idea that we're reducing cognitive activity or stimulation, it shouldn't surprise you that many of the side effects involve drowsiness, fatigue, some sort of slowing down of cognition. Also, just as an interesting point and a notable one, women who are pregnant are asked not to take these because they have been linked to abnormalities in babies, such as birth defects. As far as benzodiazepines go, they are best for temporary relief for anxiety, but this is not often long-term interventions. We try to combine that with some other behavioral therapies we'll look at later in the videos, and you can see how we move from one to the other. While we're talking about antis, let's look at antidepressants, those medications that seek to reduce or minimize mood disorders of some kind. And depression will be the big one we'll look at, though I will make reference to bipolar as well. We're going to look at three main classes, starting with tricyclics. And if you've taken a chemistry class, you may have diagrammed sort of chemical bonds of these molecular structures. Well, tricyclics, like their name implies, have three rings. These certain medications will increase the levels of neurotransmitters, specifically norepinephrine and serotonin. We're going to see those two neurotransmitters again and again in this class. We find of all the medications we use for depression, tricyclics are some of the best in terms of their effectiveness in use. About 60 to 70% of cases see a reduction in depression symptoms. However, it does often take 2 to 4 weeks to start seeing those benefits, and that's an important point. One difficulty we have in medications and psychopharmacology is getting patients to continue to take their meds or not taking them long enough for the effects to happen. We do sort of have this mentality that if I take a medicine for 1 or 2 days and nothing happens, then it's not working, this idea of immediate relief. But for these medications, it may take weeks to alter the brain's chemistry. Now, there is a subcategory called tetracyclics, and like my diagram shows, we have 4 ring bonds. I just wanted to mention this because in recent research we found that this is one of the most effective chemical reducers of depression. So these tricyclics and tetracyclics, which are a bit of an older older prescription, are still out there and still being used well. The second class of antidepressants I want to show you is MAO inhibitors. Monoamine oxidase is an enzyme that breaks down neurotransmitters, specifically serotonin and norepinephrine. Here they are again, and here we are still talking about mood. Now, you might remember from chapter 2 that for neurons to fire, the electric pulse has to hit the terminal buttons, but there's a gap. There's a space between that neuron and the next neuron. And for that electric signal to continue, we must have certain neurotransmitters present to activate to keep that signal going. Once the signal passes, those neurotransmitters are reabsorbed or reuptake. Well, in this case, this enzyme that's there to break down the neurotransmitters and to let the neurotransmitters return home, this MAO inhibitor, as it sounds, causes those neurotransmitters to stick around. These are not typically as well, or not well used, and not as often used, and that's because while they are effective, they have much more serious side effects. They have potentially harmful interactions with fermented foods such as cheese or alcohol that causes a raise in blood pressure and has been shown to cause stroke. So if patients are on these specific antidepressants, they will come with dietary restrictions. Finally, we have SSRIs, something I made reference to many videos ago when we talked about the brain. Once again, we're talking about serotonin, a neurotransmitter linked to mood. And once again, we're talking about a medication that keeps the serotonin around longer, so those neurons will continually fire more often. The most widely known SSRIs are what I've put here: Prozac, Paxil, Zoloft. I mention those name brands because I bet you've probably heard of them. You've seen them on TV or commercials. That's why. They are quite effective, though like any medication do have possible side effects. Often the big side effects have to do with sleep regulation, either too much or too little, so insomnia or being drowsy a lot of times. We do see in some individuals heightened anxiety and even impaired sexual function. Now, I mentioned bipolar in the previous chapter when we talked about mood disorder, and I just want to make reference to lithium, a metal in the periodic table, an element that you've probably heard about or heard people make mention to. This is an effective treatment, but it also can be very toxic, and so it must be carefully monitored, and that's why lithium is not necessarily the first go-to medication for bipolar disorder. Now, if you look at the data, especially since the 80s, you will notice that we have an almost 400% increase in the amount of antidepressants that we're prescribing. And at first glance, that may look high, and certainly it is high, but there's something kind of interesting about this category of drugs I want you to realize, and that is over half of all prescriptions of antidepressants are not for depression. That's because of a phenomenon known as off-label prescriptions. This means that physicians, pediatricians, psychiatrists have noticed that these drugs, though they were created for one specific cause, are effective at treating other problems as well. Sometimes even the side effects of medications can be a benefit depending on the situation. So it's common to see some people prescribing antidepressants for things like anxiety disorders, eating disorders, which is linked to things like OCD, and even sleeping disorders. Now, in terms of giving medication to children, this is still controversial. In part, that's because the best drug studies are controlled trials where we have a control group, an experimental group, one gets a real drug, one gets a placebo, and then we find what's the accurate effect of this medication. However, there are very few drug trials done on children, and understandably so. Few parents would want to volunteer their kids for drug trials unless it was an absolutely serious or necessary life complication. And so knowing exactly what doses to give children and if we should give children medication or what other interventions are there, certainly food for thought and a matter of debate and something that we are talking about. Now, one last class of drugs, let's look at antipsychotic drugs, and not surprisingly, we're going to talk predominantly about schizophrenia. Remember in the last video, schizophrenia is marked by severe positive symptoms like hallucinations and delusions. And so these antipsychotic drugs are there to help reduce those abnormal or those positive symptoms, but also to improve some of the negative symptoms such as social behavior and better sleep patterns. The most common, at least in terms of what you may have heard of, is called neuroleptics. These are antipsychotic medications. Remember, psychotic means disconnect or break from reality, so these medications are there to reduce symptoms. Let's be clear, these medications just treat the symptoms. They don't inherently cure schizophrenia. There are cases of men and women who are schizophrenic who both through drug trials and therapy have shown marked improvement and perhaps even have weaned themselves off of one or the other based on the program. But in many cases, schizophrenics may need to maintain some sort of medical intervention regularly to keep these symptoms at bay. Now, while neuroleptics are quite effective at treating creating antipsychotic behaviors, we do find they have side effects like any other drug. Neuroleptics do reduce dopamine as part of their process, and we find that can create reduced pleasure in men and women. So basically the things that bring you joy, pleasure, that engage you in this world may stop doing so. Also, while it's a bit rare, it's important to note that tardive dyskinesia a disorder of movement, basically facial tics, tongue movements, mouth, twitching body parts. This is something that can happen. About 20% of people taking neuroleptics do show tardive dyskinesia. You can Google it and see several videos of men and women demonstrating these physical abnormal movements. Because of this, we have been looking for other antipsychotics, and there's a class that came about in the 90s called atypical antipsychotics. Things like clozaril or Risperdal might be one you've heard of before. They also affect dopamine and in this case serotonin, but we find based on the smaller and more frequent doses, atypical antipsychotics do not have those side effects we previously mentioned. Now I got two more physical or biological interventions to mention. The first is ECT or electroconvulsive therapy. You may have heard this called shock therapy. You may have seen movies and TV shows where patients were willed and indiscriminately shocked as part of punishment or torture or just scientific curiosity. Unfortunately, that is something that did happen in the past, though, however, today ECT does not resemble what it did many decades ago. It was created in the 30s, and the idea is to introduce small electric currents to create small micro seizures in the brain. It turns out this acts as sort of a rebooting mechanism and actually provides an amazing amount of relief for some people. Today we still use ECT, about 100,000 cases a year. Typically they're patients who have shown no improvement in other medical or therapeutic interventions, depression being the most common one. Today, if someone were to get ECT, much like you see in the picture there, it doesn't resemble the strap on the table, thing in your mouth, torturous act. It's like any other minor medical procedure that involves surgery. Typically, the patient is under anesthetic. They might be asleep. They typically have no memory of the process. Now, there are some side effects. We do find minor memory loss and some other cognitive impairments. The fact that we are creating these micro seizures does indicate the seriousness of this particular treatment. That's why it's done more rarely. But again, and given the choice between no intervention, no treatment, and no help, and a possible help, ECT is still a great choice. As I said, it is useful, it is quite effective, and in fact, men and women who respond to ECT often report feeling better much faster than other interventions such as medications or behavioral interventions. One last thing to mention about ECT is there is sort of a new frontier of science where we actually directly wire electrodes into the brain and has already shown remarkable abilities to help severe cases of depression and OCD. So this might be a part of the frontier of psychology and psychiatry, is finding a way to directly alter the brain without using chemical intervention. Lastly, we have psychosurgery, which is just what it sounds like, doing surgery on the brain. This is a last resort, a last-ditch effort when all other treatments have failed. It's a very serious intervention, one that is completely permanent. Typically with psychosurgery, you are cutting, removing, burning, lesioning. You're basically destroying a small area of the brain that we believe is causing the problem, hoping that the rest of the matter can take up the slack. If done professionally and correctly, oftentimes it can be useful. It has been successful in treating a number of problems such as depression, anxiety, obsessive compulsive behavior, or even other erratic and dangerous behaviors. But this is a serious and potentially risky procedure. Many of you have heard about prefrontal lobotomies, which is the idea of destroying part of the frontal lobe. In the early days of its process, it was little more than a spike pushed behind the eye and hammered into the brain. Unfortunately, like with ECT, decades of use of it saw it to be quite indiscriminately used as a form of punishment or control or experimentation. So it does have a terrible connotation, and understandably so. In a modern world, if you were to experience psychosurgery, it would be like any other surgery. We have pinpoint accuracy with lasers, blades. We have the technology to make as minimal damage as possible. All right, we're going to stop there. When we come back, we're going to look at a whole different range of therapies. In this case, not looking at drugs, but looking at person-to-person contact. See you then.